Welcome to the PAT podcast. I'm Shafir Ahmad, your host, with new exciting episode. So stay tuned in. Please follow me on YouTube, Twitter and Instagram with the handle bar at ShafirAhmad4109. And please feel free to share these chunks of knowledge. Thank you. Today, the topic of discussion of our podcast is endometrial carcinoma. Now, before going into the detail of endometrial carcinoma, first of all, let's try to briefly review the histology of endometrium. So, the endometrium consists of a single layer of columnar epithelium plus the stroma on which it rests. So endometrium is basically comprised of columnar epithelium and it's sitting on a stroma. Now the stroma is a layer of connective tissues that varies in thickness according to the hormonal influences. Now in the uterus, simple tubular glands reach from the endometrial surface through to the base of the stroma, which also carries a rich blood supply provided by the spiral arteries. Now, in someone with a uterus of reproductive age, two layers of endometrium can be recognized. Now, these two layers occur in the endometrium lining the cavity of the uterus and not in the lining of the fallopian tube, which are lying above the uterus. So, what are these two layers called? These two layers are, one is called functional layer and the other is called basal layer. Now the functional layer is adjacent to the uterine cavity and this layer is built up after the end of menstruation during the first part of the previous menstrual cycle. So its proliferation is induced by estrogen in the follicular phase of the menstrual cycle, and later changes in this layer are engendered by progesterone from the corpus luteum, which is increased in secretion during the luteal phase. Now, it is adopted to provide an optimum environment for the implantation and growth of the embryo, and this layer is completely shed during menstruation. Now, the functional layer will be completely shed during the menstruation phase of the menstrual cycle. The other layer that is present adjacent to the myometrium is called basal layer of the endometrium, and it is below the functional layer and is not shed at any time during the menstrual cycle. It's like that, constantly present in the endometrium, and it's not shedding away during any time during the menstrual cycle. So what does the basal layer contain? It contains the stem cells that regenerate the functional layer. So what is functional layer? That develops on the top of it is known as functional layer. So in the absence of progesterone, the arteries supplying the blood to functional layer constrict, so that cells in that layer can become ischemic and die and eventually lead to menstruation. So it is possible to identify the phase of menstrual cycle by reference to either the ovarian cycle or uterine cycle by observing microscopic differences at each phase. So what is the epithelium which is present during the menstrual phase? You will not find any epithelium in the endometrium and the layer will be thin. In follicular phase, however, the thickness will be intermediate and the epithelium which is predominant at that time is columnar epithelium. Then in the luteal phase, the thickness of the endometrium will be increased as compared to the follicular phase, and the epithelium will be columnar, and there will be also visibility of arcuate vessels of the uterus. And then in ischemic phase, the thickness is variable, but the epithelium is still visible as columnar, and also visible are arcuate vessels of uterus. So after discussing briefly the histology of the endometrium, so before jumping into the endometrial carcinoma, we have to discuss the concept of endometrial hyperplasia. So hyperplasia means that increased in cell number. So endometrial hyperplasia occurs when there is an excess of estrogen relative to the progesterone or progestin. And if it is in excess, if estrogen is in excess sufficiently for prolonged period of time, so it can induce exaggerated endometrial proliferation, which is also known as hyperplasia. And this hyperplasia is an important precursor of endometrial carcinoma. So potential causes of estrogen excess include when there is failure of ovulation, such as seen during in the perimenopausal phase, when there is prolonged administration of estrogenic steroids without counterbalancing progestin, and estrogen producing ovarian lesions, for example in polycystic ovarian disease or in the tumor of ovaries, for example granulosa theca cell tumors. So common cause of estrogen excess is obesity. So what happens in obesity is that adipose tissue is converting steroid precursors into estrogen. So the more the obesity is there, greater the chances of increase in estrogen, and hence when there will be increase in estrogen, what will happen that there will be endometrial hyperplasia. So the severity of the hyperplasia is correlated with the level and duration of estrogen excess. And this hyperplasia is classified based on architectural crowding. So it can be either simple or it can be complex. So we have two different types of hyperplasia in the endometrial hyperplasia. Either it is simple hyperplasia or it will be complex hyperplasia. And the presence or absence of cytologic atypia. So what I mean by cytologic atypia? So first of all, we will have to understand what atypia is all about. So atypia is the histopathologic term for a structural abnormality in a cell, and it is used to describe atypical cells which are not typical, simply put in. So atypia can be caused by infection or irritation, for example if diagnosed in the pap smear, for example. In uterus, atypia is more likely to be a precancerous lesion. So, for example, what is atypia? Let us try to further elaborate this concept. That features that constitute atypia have different definition for different disease, but often include the following nucleus abnormalities. So when you are seeing some of the nuclear abnormalities which we will discuss right now, so you can refer those abnormality as cellular atypia. For example, nucleus is enlarged, it is pleomorphic, or nucleus is showing nuclear polychromasia, which means that there is variability in nuclear chromatin content, or you are seeing the numerous mitotic figures inside the nucleus. So then you can say that this is an atypia. So in contrast, a related concept is dysplasia, that refers to an abnormality of development and includes abnormalities on larger histopathological scales. So we will give an example of a Barrett's esophagus, that in Barrett's esophagus features that are classified as atypia but not dysplasia are mainly: number one, nuclear stratification, wherein cell nuclei which are normally located nearly at the same level between adjacent cells are instead located at different levels. Crowding, hyperchromatism, or the prominent nuclei. So these are some of the examples of atypia. So when I'm referring to the atypia, you can always imagine that something is wrong with the nucleus, like there is nuclear enlargement, there is nuclear pleomorphism, there is nuclear polychromasia, or there are numerous mitotic figures. So now let us try to discuss about the simple and complex hyperplasia. So what we have said that endometrial hyperplasia is divided into either simple or complex hyperplasia with the presence or absence of cytological atypia. So the most commonly used classification for endometrial hyperplasia is the World Health Organization WHO system, which previously had four categories: simple hyperplasia without atypia, complex hyperplasia without atypia, simple atypical hyperplasia, and complex atypical hyperplasia. So in 2014, the WHO updated the classification system and removed the distinction between simple or complex hyperplasia, instead only relying on the presence or absence of atypia. So simple hyperplasia of endometrium is defined as when there is irregularity and cyst previously, that includes cell stratification, tufting, loss of nuclear polarity, enlarged nuclei, and increase in mitotic activity. So these are all denoting yes to cellular atypia. So these changes are similar to those seen in the true cancer cells, but atypical hyperplasia does not show invasion into the connective tissue. That's a defining characteristic of cancer. But these atypical endometrial hyperplasia can lead toward full-blown endometrial carcinoma when it will start invasion. So this is an important precursor lesion for endometrial carcinoma. So let us try to review again that the severity of hyperplasia is correlated with the level and duration of estrogen axis and is classified based on architectural crowding, which we have discussed right now, which will be either simple versus complex, and the presence or absence of cytological atypia. So the risk of developing carcinoma is related to the presence of cellular atypia. So cellular atypia is the defining characteristic for developing carcinoma. Simple or complex hyperplasia doesn't account into this category because whether it is simple or complex hyperplasia but there is no cellular atypia, there is no risk of developing endometrial carcinoma. So complex hyperplasia without cellular atypia carries a very low risk, much less than 5% for progression to endometrial carcinoma, while complex hyperplasia with cellular atypia is associated with much higher risk, 20% to 50% risk of developing into endometrial carcinoma. So when there is no atypia, there is much less than 5% risk of developing full-blown carcinoma, but when there is cellular atypia, there is almost 50%, greater than 10 times risk than when it is having no cellular atypia. So when hyperplasia with atypia is discovered, it must be carefully evaluated for the presence of cancer and must be monitored by serial endometrial biopsies. So in time, the hyperplasia may proliferate autonomously, no longer requiring estrogen, and eventually may give rise to carcinoma. In a significant number of cases, the hyperplasia is associated with inactivating mutations in the PTEN tumor suppressor gene, which is an important brake on signaling through the PI3 kinase/AKT signaling pathway. So acquisition of PTEN mutation is believed to be one of the several key steps in transformation of hyperplasias to endometrial carcinoma, which also often harbor PTEN mutations. Now we will discuss about endometrial carcinoma. Now after discussing the endometrial hyperplasia, let's come towards the endometrial carcinoma, that what endometrial carcinoma is all about. So in the United States and in many Western countries, endometrial carcinoma is the most frequent cancer occurring in the female genital tract. Generally appears between the ages of 55 and 65 years and is uncommon before age of 40. So endometrial carcinoma comprise two distinct kinds of cancers. So on histology, you will find two distinct kinds of cancer. One is the histology of endometrioid and the other is the serous carcinoma histology of the endometrium. So these two types are histologically and pathogenetically distinct. So endometrioid cancers arise in association with estrogen excess and endometrial hyperplasia in perimenopausal women, while serious cancers arise in the setting of endometrial atrophy in older postmenopausal women. So, the histology and the age of presentation of both of these histological subtypes is different. So let us see how morphologically this endometrial carcinoma will behave. So endometrioid cancers, which we have said that which usually arises in the premenopausal phase, they closely resemble normal endometrium, just like we've discussed in the start about the histology of the endometrium. So they are closely resembling the normal endometrium, and it might be exophytic or infiltrative. And they include a range of histological subtypes, including those showing mucinous, tubal or ciliated, and squamous differentiation, or maybe sometimes you will also see adenosquamous differentiation. So, tumors originate in the mucosa and may infiltrate the myometrium and enter the vascular spaces. And they may also metastasize to regional lymph nodes. So, endometrioid carcinomas are graded 1 to 3 based on the degree of the differentiation. And in contrast, serous carcinomas, on the other hand, form small tufts or papillae, and they will form small tufts and papillae rather than the glands seen in the endometrioid carcinoma and exhibit much greater cytological atypia. So, much more chances of getting a carcinoma. They behave aggressively and thus are by definition high grade as compared to endometrioid carcinomas. Immunohistochemistry often reveals a high level of p53 in serous carcinoma, a finding which usually correlates with the presence of p53 mutations because the mutant p53 accumulates and more easily detected by staining. So, what about the pathogenesis of endometrial carcinoma? So, the endometrioid type accounts for 80% of cases of endometrial carcinomas. These tumors are designated endometrioid because of their histological similarity to the normal endometrial glands, and the risk factors for this type of carcinoma include obesity, diabetes, hypertension, infertility, and exposure to unopposed estrogen. So many of these risk factors which we have stated like obesity, diabetes, hypertension, infertility, they usually result in increased estrogenic stimulation of the endometrium and are associated with endometrial hyperplasia. So in fact, it is well recognized that prolonged estrogen replacement therapy and estrogen secreting ovarian tumors increase the risk of endometrioid type of endometrial carcinoma. Additionally, breast carcinoma, which also is estrogen dependent in women with endometrial carcinoma and vice versa, more frequently occur than by chance alone. By this I mean that breast cancer and endometrial cancer usually occur simultaneously. So, mutations in mismatch repair genes and the tumor suppressor gene PTEN are the early events in the stepwise development of endometrioid carcinoma. So, women with germline mutations in PTEN, also known as Cowden syndrome, are at high risk for this cancer. So, p53 mutations also occur in endometrioid type of carcinomas, but are relatively uncommon and are believed to be the late events in the genesis of this tumor type. However, the serous type of endometrial carcinoma is due to mutations in p53 tumor suppressor genes, and as we have discussed in the morphology, that you will see the mutated p53 accumulations in histology. So the serous type of endometrial carcinoma is much less common, accounting for roughly 15% of the tumors, in contrast 80% of the tumors of endometrioid. So nearly all cases have mutations in p53 tumor suppressor genes, whereas mutations in DNA mismatch repair genes and PTEN are rare. So let us summarize what we have discussed up till now is that endometrial hyperplasia results from excess endogenous or exogenous Estrogen. Risk factors for developing endometrial hyperplasia includes anovulatory cycles, polycystic ovary syndrome, estrogen producing ovarian tumor, obesity, and estrogen therapy without counterbalancing progestin. The severity of hyperplasia is graded on the basis of architectural and cytologic criteria. The architectural criteria we have discussed was simple versus complex, and cytological criteria was normal versus atypical. And the risk of developing carcinoma is predominantly related to cytological atypia, in contrast to it doesn't take into account the simple versus complex hyperplasia. So the cytological atypia is the major risk factor for the developing carcinoma, the full-blown carcinoma. And on the basis of clinical and molecular data, two major types of endometrial carcinoma are recognized. One is endometrioid carcinoma, which is associated with estrogen excess and endometrial hyperplasia. And the early molecular changes include inactivation of DNA mismatch repair genes and the PTEN genes. Serous carcinoma of the endometrium arises in the older women and usually is associated with endometrial atrophy, and mutations in the p53 genes are the early events. And finally, the stage is the major determinant of survival in both types, whether it is endometrioid or serous. So serous tumors tend to manifest more frequently with extrauterine extension and therefore have a worse prognosis than the endometrioid carcinoma. For further questioning related to the topic, feel free to email me at shafirehman@hotmail.com.